We are live.
Good evening, everyone. I welcome you all to yet another online iFocus session. Today is lecture number 556, and currently we are running in 31st Optics and Refraction module. Today we have Dr. Sandra Ganesh ma'am, consultant at Aravind Eye Hospital, Coimbatore, to teach us about cycloplegic refraction and pediatric refraction. Welcome, ma'am.
Thank you.
To moderate today's class, we have our dear Dr. Amita Kaul, ma'am. Ma'am holds a degree in Masters of Surgery in Ophthalmology and is a university certified cornea and refractive specialist with more than a decade of clinical experience. After finishing her MBBS and MS from Government Medical College Jammu, she did her fellowship from RGHS at Bangalore. She has been trained at prestigious institutes like Narayana Netralaya Bangalore, LV Prasad Eye Institute Hyderabad, and Shankara Eye Foundation Bangalore. With more than 12 years of ophthalmology experience, her expertise and interest lies in lamellar corneal transplants, lenticle-based refractive surgery, ocular surface disorders, its management, and refractive cataract surgery with a strong emphasis on evidence-based clinical approach, research interest, and academic education. Currently, we are fortunate to have ma'am as a senior consultant at Center for Sight Eye Hospital, New Delhi. She is involved in teaching and training of DNB students and anterior segment fellows. Ma'am has more than 20 peer-reviewed publications on cornea, cataract, refractive, and surface procedures, and she has delivered lectures in national and international conferences. Welcome, ma'am, and over to you for the introduction of our chairperson and our speaker.
Thank you so very much, dear Kritika. Am I audible?
Yes, ma'am.
It is a great privilege for me to be hosting this session today alongside Kritika, and I'll directly go on to speak about Dr. Praveen Kumar, sir, who is the chairperson for today's session. Sir is an MS Ophthalmology Gold Medalist from AFMC Pune, and he has done his DNB, FACO in glaucoma and FICO. He also holds a fellowship in Pediatric Ophthalmology and Strabismus from Shankar Netralaya, Chennai, and he's trained in glaucoma and cornea at JIPMER, Puducherry. He's currently the Assistant Professor, Department of Ophthalmology at ACSR Medical College, Nellore, and he has more than 14 years of ophthalmology experience. Sir has been an exam coordinator for undergraduate and postgraduate practical examinations in JIPMER, undergraduate and postgraduate examination in Dr. NTR University, RGUHS, and MG-RGUHS. Best Paper Presentation Award in Conference 2013, and he was the winner in Intercollegiate Ophthalmic Quiz, RADNET, in Chennai 2015. There are numerous publications and presentations, both at national and international conferences, to his credit. Welcome to this session, sir. We look forward to learning more
Thanks a lot,
from you.
madam. Thanks.
It's an absolute
Thanks a
pleasure.
lot. Thanks a lot for introducing me, ma'am.
It's
Even
also
to
an
me, even me,
absolute
ma'am. Thanks a lot, ma'am.
pleasure, sir. It's an absolute pleasure again to be
Thanks.
introducing Dr. Sandra Ganesh, DNB, FICO. She's currently the medical consultant in pediatric ophthalmology and strabismus, Aravind Eye Hospital, Coimbatore. She has more than 20 years of work experience. She's a reviewer for JPOS, BNJ Open Opthal, and IJO. She has more than 43 publications with more than 96 citations to her credit. She has also received the Best Paper Award in Pediatric Ophthalmology, Strabismus, at Tamil Nadu Ophthalmic Association, running in 2011, 2012, 2023, and in AIOC 2015. She has presented in various national and international conferences. She is also a part of the USAID LVA project 2014-16 and Vision Aid project 2024 to 27, which is currently running. And she has a special interest in complex strabismus, myopia, CVI, amblyopia, and NSPVA. She's also a passionate musician and also takes interest in films and poetry. Welcome to this session, ma'am. We look forward to learning more from you. With this, I'll hand over the podium to Dr. Sandra to
Thank you
share
so
her
much.
screen.
Yeah, thank you so much for the organizers and for the very kind invitation. And it's my pleasure. I've always been loving to teach, and today I'll be talking about pediatric refraction and cyclorefraction. So something very important for everyone who's associated with treating children. So coming to just some introduction about childhood refractive errors. It's the most common cause of visual impairment worldwide and also in India because of ours is a young country in the sense the percentage of children is much more in our country as compared to the West. And world over, it constitutes like 18.2% 2% of blindness. And WHO, according to the statistics, about 19 million children are there less than 15 years, so visually impaired, and out of which majority are due to uncorrected refractive errors alone and amblyopia. So it's huge. So this is the most common condition that you will be seeing wherever you practice or see any child less than 15 years of age. It's a huge economic burden considering the number of years of life. And if it is myopia, any pathological or high myopia has blinding complications associated with it. So there is an improved quality of life quotient and definitely a lot of social, educational, and economic consequences. So the etiology of refractive studies are multifactorial, both genetic and environmental. And a lot of what we understand today has come from studies on twins, parental refraction, especially in myopia. With one parent myopic, you will be looking at probably 10 to 20% higher risk for the child. And with both parents, there's more higher risk. Ethnicity, Southeast Asia and India, there's a high risk of myopia as compared to Caucasians and the West. And there are a lot of hereditary conditions which are associated with certain refractive errors, which I'll be showing you, and also birth weight. And there are environmental influences as well, which includes outdoor, maybe it is related to increased dopamine in sunlight levels, ambient lighting inside the rooms, prolonged near activity, especially with digital screens, high pressure educational systems, and overuse of near electronic devices has created a pandemic within a pandemic. Especially in the last 5 years, we are seeing an overwhelming incidence of myopia. And there are other factors to play, like accommodation, like weak accommodation linked to myopic progression, socioeconomic status, and etc. So before we talk about the refractive errors, we also need to know what is normal. So most of the children, when they are born hypermetropic. Around +2 to +3 will be the hypermetropia that you will see in a normal newborn. And a few of them can be myopic. The factors, and then there is a process obtaining to get a greater frequency of emmetropia. That's called as emmetropization. So there are a lot of factors in place. As the child is born, the axial length is less and the cornea is more steep. And the factors which influence emmetropization will reduce the corneal power, crystalline lens power, axial length, and also the AAC depth. So any of these which can fail, if there is failure, it leads to hypermetropia. Where there is an overshoot, there will be myopia. So at birth, the child's eye is really small. The anteroposterior diameter may be just around 17 millimeters, whereas an adult, on average, it is around 23 to 24 millimeters. And the child's eye is really steep. As you can see, it's around 55 to 50 diopters at birth. And then slowly within the first year, the K reading drops. The adult K reading is just around 40 to 44 or whatever you consider as normal. And similarly, there are changes in the optic nerve length, corneal diameter. Corneal diameter is almost the same as the adult size even at birth. Corneal thickness is slightly thicker at birth and then reduces. And also there are changes in the pars plana length and orbital volume. So as I said before, on an average, the babies are born with around +3 hypermetropia. By the end of 1 year, it reduces to around +1. And as the child continues to emmetropize and see, the critical periods for development of binocular vision is around 5 to 7 years of age when you get the high-grade stereo acuity. When the child is born, the visual acuity is quite poor the day the child is born. And there is a rapid increase in the visual performance. By around 1 month, the child starts fixing, following, and tracking objects. And around 6 months, we would be diagnosing infantile strabismus. So the effects of uncorrected refractive errors are a lot. It can lead to amblyopia or lazy eye, strabismus, and any severe impairment of vision can affect all the developmental milestones. It's very important to note that the majority of the ocular growth occurs in the first 18 to 24 months of life. So this is again a repetition. The spherical refraction of healthy neonates are hyperopic. When the children are born preterm, like with a birth weight of less than 2.5 kg, you can expect myopia, and the myopia is more in children who are born with higher grade of retinopathy of prematurity or treated ROP or who undergo surgery. So those children, there is a higher incidence of high myopia and also astigmatism. So by 3 to 5 years of age, the process of emmetropization is going on, but you can still expect spherical refractive errors, myopia, astigmatism, and anisometropia. In adolescence, if the child you're getting a myopic, like a less than normal hyperopic reflex at around 5 to 6 years of age, there is a higher incidence of myopia. So you call that as a pre-myopia. So what is pre-myopia? Getting a hyperopic reflex for that age, which is less than what you will expect at that age. For example, the retinoscopy at a distance of 1 meter for a child age 5, you must be looking at a shadow of +2. Or if you're going to get something less than that, let's say you say looking at +1 or +0.5, then definitely the child develop myopia. So that you can do a prediction like that. And around the age of puberty, there can be another risk of progression of myopia. So there are certain ocular and systemic conditions associated with refractive errors as well. Like if you have a child who's diagnosed to have Marfan syndrome where you have a collagen anomalies, the sclera is thin, the eyeball grows to become myopic. And Stickler syndrome, where you have vitreous degenerations, congenital stationary night blindness, gyrate atrophy, congenital glaucoma, ROP, as I said before. So all these are associated with myopia. Certain conditions like Leber's congenital amaurosis can have high degree, grade of hyperopia. So if you see a child whose visual behavior is very poor and also has a high hyperopic reflex, it would you should and nystagmus, roving nystagmus, then you will be thinking in terms of Leber's, cornea plana, astigmatism. If there is a ptosis, even a mild ptosis, you should be doing refraction because there could be some astigmatism associated with it. Even a big dermoid or even a big chalazion at time, long-standing, can lead to astigmatism. Any cause of corneal scoring is a cause of astigmatism. So when it comes to children, you will definitely have unique challenges as compared to adults, because a child's visual attention is very less, and you need technique to examine a child. You need expertise. You have to use a variety of technique. You need to get your information quite quickly and without making the child uncomfortable. Children have high accommodation, and hence your dynamic retinoscopy can varying results. So there is an importance of cycloplegic refraction. Lack of communication, and you need to rely more on objective methods of assessments. And there is a dynamic ocular system due to growth and amblyopia risk and all. So there are a whole lot of challenges which are unique to children as compared to adults. So in low risk infants, by which I mean a child born with a normal birth weight and no perinatal or neonatal risk factors, you can do the first exam by 6 months to 12 months, which is an ideal case scenario, at least by preschool. If it would be good if all the preschools have a mandatory vision exam mandated by our government. So because many of them are not unaware of, especially anisometropia leading to amblyopia or any cause of vision loss in one eye, the parents are usually not aware of. So it is good to have a preschool exam for all children, and then yearly thereafter till 18 years of age. So when do you want to, again, there can be a presenting complaint, because if the parents or children notice abnormal visual behavior such as going unable to see the blackboard at school or going close to the television, tearing of eyes, eye strain, headache, watering, recurrent chalazion, and intermittent strabismus, all the, or any poor performance in school. So all these can be presenting complaints for detailed examination. So again, when the child comes with the history of such complaints, you need to also go into the birth history, general health, behavior, milestones, and the family history. And behavior in the sense, in an older child especially, you need to look at the hours of outdoor activity, hours of near activity, smartphone or digital media usage, and or the family, whether the siblings or parental history of myopia. So all those history needs to be documented, because that will help you to come to a decision for treatment. And there are certain exams which you can do in a certain sequence, like you can do the entrance testing, can be involve just a confrontation field, looking at trying to look at the saccade, pursuit, the extraocular motility, and the pupil function. Hirschberg reflects along with that. And it will be good to start with the stereo testing in an older child, because once you cover the eye, then you can disrupt the stereopsis there. So even in children as young as 3 or 4, you can get a good Langs or a Frisbee stereo acuity. And color vision testing is quite important, because you can uncover this problem which may not, the parents may not be aware of. Retinoscopy, then you can look at the visual acuity, intraocular pressure, dilated, and cyclorefraction. So that way, this order could be good for the cooperation in the child. Because if you cover the eye and the child starts, like for measuring visual acuity, the child may feel apprehensive and start crying, then it will be difficult for you to get the other exams done. So establish a rapport with the child, not just the parents. And for a child less than 1 year, the visual testing can involve the optokinetic nystagmus with an OK and drum, where rotating the drum with the thickness of the stripes, you will notice a nystagmus pattern in the child. And when you no longer notice it, that will be the visual acuity. Preferential looking test like tellers, and the examiner sits behind the teller and they show the teller cards and look at whether it is a forced preferential looking. That is, the child prefers to look at a pattern strabismus, patterned stimulus, rather than a plain background. So the thickness of the lines again would dictate the least thickness which the child is seeing will determine the visual acuity. The same principle holds with the Lea paddles as well. And you will be using the Lea paddles even in older children, but with the developmental delay. Then visually evoked response, like the pattern or the VEP can be used. With a pattern or a flash VEP will just help you to know the optic nerve response, whereas the pattern VEP will help you to even measure the visual acuity, which can be quite accurate. And then you can divide the children as infants, toddlers, preschool, and school age. So for toddlers, you can have like the matching pictures, the K pictures, the Allen cards. You can have the Cardiff cards. And in the preschoolers, again, you can have the HOTV, and then you can Snellen's or the Logmar chart in the school age. And you can see based upon the fixation pattern also. If the fixation is, we call it as CSM, that is central, steady, and maintain. That is, central means the quality of the fixation when you shine a torch, and steadiness of the fixation on cover. And if it is maintained even after removing the cover, then the visual acuity is pretty good. Whereas if it is central and steady but not maintained, then the visual acuity could be in the range of 6/36 to 6/60. Whereas if it is an unsteady fixation, then the visual acuity is less than 6/60. It's an approximate guide. So we have made this chart for knowing the visual developmental milestones. Like for any child, like it's a easy step ladder approach, like 3 months. By 3 months, this is the latest at which the developmental milestone should be attained. Like at the age of 3 months, the child looks at the mother's face, should be attained, and even the social smile. By 6 months, they try to touch objects. By 9 months, the pincer grasp is developed. They can pick up objects directly. 12 months, imitating others' actions. 2 years, observe the pictures, 3D to 2D. And 36 months, a child starts drawing on the floor. So this is somewhat easy for the parents to check their toddlers or kids' milestones. And positioning, usually in a very small children, they are held. In preschoolers and toddlers are comfortable on the parent's lap. And school children, they can sit alone with the parent nearby. Do not miss a tie or a ptosis, because it can lead to astigmatism. So Retinoscopy is the generally most satisfactory and accurate method of objective determination of refraction. However, it's an art, cannot be learned from books. For efficiency can be attained only by long, assiduous and painstaking practice, as quoted by Duke Elder. But nowadays, even in adults, the quality and the number of people who are trained to do retinoscopy is decreasing, especially with the advent of the autorefractors. This technique is gradually becoming, there are less and less people who are training themselves to do refraction. But in children, the autorefractors are not going to give you a good guide. They definitely need to train in retinoscopy. Also, when you look at the reflex, that can be a Bruckner's reflex, that is the shadow that you see on the pupils, can also give you a guide to the refractive error. There has been papers on utilizing the Bruckner's reflex alone in school screening for picking up refractive errors, like you can pick up myopia, emmetropia, and hyperopia based on where you are seeing the crescent. And this can also, it will help you to evaluate strabismus, like the eye with the brighter reflex will be the deviated eye. So the techniques of refraction will include the objective, that is the retinoscopy, which can be dynamic, that is like without the cycloplegic agent, or static, which is with the cycloplegic. And also about autorefraction, photorefraction, and subjective refraction is definitely mandatory in older children to verify your objective retinoscopy findings, and also to give the titrate, especially the little tweaking the axis for us to get the child's, based on the child's comfort level. And but the session should be short with positive reinforcement. Do not scare the child, and otherwise you are not going to be able to complete your examination. But the poor patient fixation, especially young children, high refractive errors, irregular astigmatism, and media opacities can pose a challenge. So I have told this before, like in infants, you use the tellers or similar, the rotating drum, and completely it's objective, short examination. So you also will focus on the fixation behavior, the oculomotor control, the pursuits, the horizontal tracking, scanning, retinoscopy, cover test. So based on all this, we'll have to come to the conclusion regarding the visual acuity. There is also technique. Certain children, you will not be are higher risk for adverse effects to cycloplegic, like low birth weight, neurological seizure disorder. In these kids, you can do something called as a near retinoscopy or Mohindra's reflex, where you can do in a completely dark room on a retinoscope with just a filament, where this is not an accommodative stimulus. You do at a distance of 50 centimeter. So here, that you can keep the tonus factors plus 0.75. The working distance is -2. So you have to subtract like -1.25. So that can be done. And here you can see the refractionist. She's looking, you can see the child looking at the pattern stimulus there. So you can see the movement of the eye. So it's like you need to move both the cards. Otherwise, you're not going to get a good response. The child will be just looking at the movement alone. So now the child has stopped fixing. So maybe that will be the threshold of visual acuity. So the child is very comfortable sitting on the parent's lap here. So, and again, you have to keep it as fun, mainly objective with some subjective components. So here you can just cover the child is not, so you have to have a way of covering. So you can see the top right, a patch has been applied, and you are making the child to pick up the 100,000 sweets. And if the child is able to pick it up, then it can be around better than 6/24 vision is what you would say. But for that, the pincer grasp should have been developed. Again, in the lower right, you can see the child pointing to the Cardiff's pictures. So it is based upon the principle of vanishing optotypes, where if based on the visual acuity, the child will be able to look at the picture which is shown on the card. And you can see the child is nicely pointing to the pictures, and based upon sometimes it can become difficult now when the child is no longer able to point. That will be the threshold of the visual acuity, and that is written on the back of the card. And up you can see the way the retinoscopy was done. So you cannot sometimes use a trial frame. You'll have to hold it freely in your hand, and you have to complete your retinoscopy. So stereo tests, again, the random tests are the most accurate because, but if not possible, you can use the tests such as the word circles or the flight test, but they do have monocular clues. So sometimes you can get incorrect responses with these, but based upon whatever test you're able to perform, you record that. And Dynamic retinoscopy is, you can see here, the girl is reading the card. So the child will first look at the distance fixation and then at the near card, and then she will be reading the letters on the card, which is stuck to the retinoscope. So here the accommodation, you can pick out whether the accommodation. So that is called as the monocular estimation method of retinoscopy. So certain conditions are associated with poor accommodation like Down syndrome, and then they'll be needing a near eye, especially children with cerebral palsy and all. You'll have to do the evaluation for monocular estimation of method for dynamic retinoscopy. So distance fixation retinoscopy, again, you can see this is the HOTV, the matching cards. So after doing the retinoscopy, the sister is doing the subjective, and the child is non-verbal, but pre-verbals, but they can point very nicely to the letters which are being shown on the matching card, which is at the child's hand. So you can see the matching done here. Coming to auto-ref, retinoscopy should form the basis of prescription in children. The cycloplegic autorefraction can be done, but provided you can ensure that full cycloplegia is attained and you're not getting. So always there should be a correlation between the objective and subjective methods. Because of the there can be a myopic reflex sometimes, and you may be over-prescribing the myopia in such children. And photo screeners are used in school screening for getting the for basically it has to be done at a distance. Many children can be screened, and it will give you a recording based on whether the child needs to be referred for further evaluation or not. You can pick up media opacities, strabismus also with the photo screeners, and you'll be getting the approximate sphere cylinder. So based on what you are getting, it shows whether to refer or whether to the child passes the examination. So it is helpful for rapid screening. So, and coming to cycloplegic refraction, why it is very important? Because children has very high accommodation amplitudes. Hence, to relax the accommodation, to rule out pseudomyopia, to find out the latent hypermetropia, you need to cycloplege. And what is latent, what is manifest, and what is total, as postgraduates you need to know. So latent hyperopia is the one that is corrected by the tone of the ciliary muscle. So that is abolished by the cycloplegic refraction. Manifest can be facultative or absolute. Facultative is what that by your effort of accommodation, and absolute, as you grow, your more of a facultative will reduce and it will become more of absolute, by abolishing the tone of the ciliary muscles. So you instill the cycloplegic drops, wait for a time, perform the retinoscopy, and record the spherical cylinder at the axis, and consider repeating instilling the cycloplegic drops if residual accommodation is there. So there are various agents. What to use? So atropine is the strongest. It is 1%. One drop, you can wait for the atropine ointment is what we usually use rather than the drops. The ointment is prescribed for BD for 3 days, and then we ask the patient to come back for refraction. So it has a long duration of action, but it's the strongest one. So you use it for children maybe less than 5 years of age with high myopia or who are having strabismus, suspected accommodative esotropias. You can use atropine in very small kids. Then coming to the homatropine. Homatropine is 2%. Again, the onset is around 1 hour and it lasts for 1 to 3 days. It's both a mydriatic and cycloplegic. And homatropine is quite safe as compared to cyclopentolate. Cyclopentolate, sometimes you get psychosis kind of presentation in small children. And but cyclopentolate acts for less duration. The duration is only like 1 to 2 days. And tropicamide is the shortest. There's a cycloplegic, but the effort wears off in 4 to 6 hours. It is mydriatic and mild cycloplegia, and onset is also quite fast. So a dilated people, you need not wait for the pupil to fully dilate. Sometimes you just look at the reaction to indicate whether cycloplegia has been achieved or not, and also how you are, when you're testing, you can make out whether cycloplegia is achieved or not. So adverse effects include local effects like some mild conjunctivitis. There can be some allergy, eyelid edema, dermatitis. Systemic on excess use, you can have fever, dry mouth, flushing, tachycardia, all the effects of like constipation, urinary retention, delirium. Sometimes it's very upsetting to the parents. Like if by mistake, if you keep putting more drops of to get the cycloplegic effect, and then suddenly the child can become irritable and have some delirium like picture, but it will wear off after some time. But better not use cyclopentolate in children with seizure disorders or any CNS pathologies. So children with Down syndrome, cerebral palsy, low birth weight, you will need a modification of dosage or use homatropine. And in role of atropine is there in children which are very young children, hypermetropic esotropia, the first time prescriptions, strong accommodation, variable refraction, pseudomyopia. You can use atropine ointment, but always tell the parent the technique of application, how much to apply, and in case of fever or any side effects, they should call back to the hospital. So compare with age-specific norms. Consider full correction versus partial, especially in hypermetropia. If there is hypermetropia with esotropia, you definitely have to give full correction. Any amblyopia, you need to give full correction. Otherwise, you correct based on the hypermetropia, you correct only if there is asthenopia. So the factors influencing prescription would be age, binocular status, the type of deviation, visual acuity, and symptoms. So myopia, it is better to give the full correction. Do not undercorrect myopia because, but when you are giving the prescription first time, if you are over minusing, then they may have problems with reading, and they may have eye strain for reading. So you need to really not overcorrect or undercorrect myopia. So prescribing glasses in children, it is based on experience rather than evidence. So what are the questions that we need to consider as ophthalmologists? Is the spectacle prescription really necessary? So if it is a very small error, like for example, you are discovering that the child has a 0.5 myopic like astigmatism only, and the child is able to read 6/9, and this is in school screening, so you would really not prescribe because it is not really necessary to correct that at that age. So what is the level of refractive error that will produce amblyopia? That you need to know, especially in anisometropia. Any interocular difference of two lines, or like you need to know when you should definitely correct. Otherwise, there is a risk of amblyopia. So when the intervention will interfere with normal immetropization, that also you need to know. So hypermetropia, unnecessarily, if you correct, it can interfere with normal immetropization. So there are guidelines which are given for correction of refractive errors in infants and children. So in age less than 1 year, if it is you are looking at really high values, so you will look at correct myopia only if it is more than -5. Similarly, hypermetropia only the very high hypermetropia. Because more than +6, the child will not be able to accommodate so much. So what will happen is the child will become amblyopic. So hypermetropia with a high degree or hypermetropia with esotropia, you will give correction, or any astigmatism. Like astigmatism more than 3 is highly amblyogenic. So even less than 1 year, you will be correcting. Similarly, for 1 to 2 years, for myopia, it is -4. Age 2 to 3 years, myopia is -3 and above. And after that, you will be correcting any myopia actually. And hypermetropia, again, you see it is decreasing. And with esotropia, you need to correct, like usually we'll give the full correction. And any astigmatism, which is significant, again, we need to give the full correction. But astigmatism, you can vary based on sometimes just on the K reading or the retinoscopy, you may get a higher value. So you base it on your subjective also. So whatever cylinder the child is accepting, and with the best visual acuity that is achieved, you correct that astigmatism. Then anisometropy, again, you have guidelines. So these guidelines are there from All India Society and from AAPOS guidelines also. So this is again a repetition. hypermetropia, full correction in esotropia, but partial in orthophoria. And if the child is not symptomatic at all, you don't have to correct hypermetropia. Myopia, again, full correction in younger children. If symptomatic, anything more than 1.5, the child is not going to be able to read the blackboard. So you need to give. And astigmatism, you have a lower threshold. If it is more than -1 cylinder, you need to give. And anisometropia, again, you need to fully equalize the image size. Similarly, if there is a high degree of anisometropia in older children, we would consider giving contact lenses because of the factor of anisoconia, especially in amblyopia, like the balancing will not be there. So this is again to show the refractive error along with strabismus. So if the child is or adult is having esotropia with hyperopia, you give the full correction. And sometimes the esotropia will be more for near. So if there is a high, there is something called as AC by A ratio. That is, the accommodation is also linked to convergence. So for every diopter of accommodation, you'll be associated with some convergence. But in certain children, this ratio will be higher. So if the convergence is more, then while looking at near, the esotropia will be more than what value you are getting for distance. So then the AC over A ratio is higher. So such children, you will need to give a higher add for near. So that is a bifocal addition. Such bifocals will need to be an executive bifocal, where which has to bisect the pupil so that both for distance and near, the child will be aligned. So especially all these accommodative esotropia, they are getting the error later, like after 2 or 3 years of age. So they have a lot of potential for binocularity and stereopsis, provided that is why these cases should not be mismanaged. Otherwise, they will become amblyopic. So myopia with esotropia is not a good combination because the myopic, especially higher myopic glasses, will increase the esotropia. So in such a combination, in older patients, we can give contact lenses that will reduce the esotropia associated with myopic error. And nowadays, we are seeing a lot of patients with divergence insufficiency with myopia in older age group who are having excessive near activity. So in those patients also, they benefit by changing to contact lens. Exotropia with myopia, it's a good combination because the glasses will also help to correct the exotropia to some extent, especially intermittent exotropia. So you give the full correction. Hyperopia with the exotropia is not a good combination, but always you should correct the hyperopia according to the visual demands. So first the vision should be given importance and then the strabismus. So nystagmus you prescribe for null zone. Sometimes it is difficult to get the endpoint refraction in null nystagmus because the visual acuity will also be not good. So you need to look at monocular and binocular visual acuity, and for monocular do not occlude the eye completely, use a partial occlusion, otherwise your vision acuity is going to drop. So always check the vision with both eyes open in the end so that will be the functional vision of the child. And over minus glasses are given in especially as a treatment in intermittent exotrope, because that will stimulate the accommodation and that will help to control the deviation. So that can be used as a like till the time you decide to do surgery, or in very young children, over minus glasses can be a way of controlling intermittent exotropias. And special situations like aphakia in younger, less than 3 years of age, you need not give a bifocal. So you can just give like 0 to 1. You can give a +3 because the child usually uses the very near vision only. So you can give the correction totally in just a single glass. And above 3 years, you can give bifocals. So accurate refraction is crucial for visual development. Cycloplegic is definitely the gold standard for children. And always you interpret the findings in the context of binocular vision and the development of the child. So doing a very good refraction, and finally, you should also be able to choose the correct frames, because always choose plastic frame. Do not go for the metal frame or the thin frame or rimless frames in small children. as they will not be able to maintain that, and it will bend, and they'll not be wearing it well. So these kind of frames are just an example what we have given. They should have a harness in the back, because the child will not know. You can have the ones with the ear loop or the harness, and you can tighten it as per necessary, so that the child will be able to comfortably play also, and use the hypoallergic material. Proper bridge fit is very important, because the nose bridge is not well formed, and sometimes the child may have some deformities in the ear or so you'll have to pay attention. The polycarbonate material is non-breakable, but it can scratch, and but definitely it is more safe. Always have a backup pair in children. And sometimes the word about like in children with myopia, you can use the special glasses, which are the myopia control spectacles can be used, which will help to control the progression of myopia by around 60 to 70%. So those glasses are also in the market for the last couple of years. And that because every diopter of progression will increase the risk of myopic maculopathy and degenerations. And it's always important to try to maintain the axial length less than 26 as much as possible, in order to avoid vision threatening or complications and loss of vision in the, like, especially with the family history and sibling myopias. So uncorrected refractive error in children can definitely lead to a lot of problems in development, education, and career, and quality of life in general. So the school screening will they are very good and active in many states in India. And but once we do the school screening, sometimes the referral uptake is very poor. And we need to make sure that the children whom we identify in the school screening are getting the benefit, and they are wearing the glasses and compliance. And many times the parents have a lot of misconceptions, and they do not want to accept that the child has a refractive error. So we have to counsel the parents regarding the importance of wearing glasses and prevent amblyopia. And later on, they can do some corrections beyond adulthood to remove the glasses. That's always an option. But not wearing the glass in childhood can lead to irreversible vision loss. So, but we also need accurate, creative, and fast retinoscopy skills, especially as a pediatric ophthalmologist. You need that skill, because you need to titrate between the objective values. We cannot just prescribe based on the objective or auto refraction alone. Encouragement and positive reinforcement is essential to get the cooperation from the child, and decide whether the indications for eyeglass will outweigh the reasons influencing the practitioner not to prescribe them. Thank you.
Thank you very much, Dr. Sandra. It was a beautiful lecture and covered all nuances of, refraction in pediatric age group, along with, I'm sure, whatever confusion or questions people would have had in their heads about cycloplegic refraction in children would have cleared. Just one question I wanted to ask. So, in your practice, what is the choice and dosing of the cycloplegic agents that you use to dilate the kids who come to you?
Yeah, usually we use cyclopentolate in our practice. And for small children, we use like CTC guideline, like 2 times cyclopentolate and 1 time of tropicamide. And we do not see many complications. So, but we do exclude the kids with high risk. And for them, who are having seizures or who are very preterm, then we use lower concentration of cyclopentolate, like the preemies and the less than 1 year age group. But if there is esotropia and a first time or a high myopia in a very small kid, we prescribe the atropine ointment, ask the parents to use it for 3 days and come back for refraction. And if we have already prescribed glasses and they are coming for reviews, like myopic reviews, then we will use tropicamide in older children. We find that good enough. And also in about 10 years of age, they find it hard to use cyclopentolate and, miss the school and exams. And also tropicamide is also good enough in the about 10-year age group, especially in the reviews where we are not, this is a small 0.25 or 0.5 change, then that's good enough.
Okay, so for younger children, like say for example, less than 8 years of age, someone who has been using glasses for say a year or so and comes back for a review, and I'm sure, like in our practice, we usually call the children every 6 months.
Yes.
So if there is no change in glasses, would you still recommend, or if there is a point 0.5 change in glasses only, would you still recommend going for a full-on dilated examination again and rechecking the number every time?
Yes, if it is a 0.25 change, we do not recommend a change of glasses. But 0.5, see, nowadays the thing about myopia management has put the cutoff as 0.5 diopters a year for diagnosing as a progressive myopia.
Correct,
So yeah, for that, if you think 0.5 in 6 months is quite significant.
correct, correct.
Hence, we will dilate and we will cross-check that definitely, because sometimes we find that in the dynamic retinoscopy, sometimes you can show an error, but after dilation, it is no
You
longer
get the
there.
right. Correct,
Yes,
correct.
yes. So if it is still existing after dilation, we will change the power. For
Right,
0.5, yes.
right, ma'am. So, Dr. Praveen will go
Madam,
on
can I
to
make a
share.
point here?
Yes, yes,
Yes.
please, sir. We were
Ma'am,
about to ask you.
apart from this dilatation and doing this retinoscopy, in myopes, this very useful for fundus examination, because if they're progressive, you can pick up certain lesions. So I
Yes.
usually do it every 6 months as
Okay,
a routine, even if they no need change of glasses, an indirect ophthalmoscopy at least every 6 months to 1 year is quite recommended nowadays, because they're progressing very fast.
right, right. So, sir, on this note, I would also like to ask, like, what precautions, if at all, can we take to reduce the systemic absorption and side effects while we are instilling cycloplegic drops? Like ma'am was saying that, there are quite a few cycloplegics which can cause systemic side effects.
Yeah,
So,
but first, if it's a preterm baby, like as madam already rightly pointed out, we can use the diluted concentrations of the drug. Number one. Number two, we can ask our assistant to do punctal occlusion, which is very important. That I routinely follow, especially in preterm and developmentally delayed babies. So that will definitely reduce the systemic absorption. And one more thing I would like to tell is, whenever using atropine ointment, we have to be very careful to educate the parents. They think if they put more ointment, it's very
Mhm.
useful. So that is the child comes back with
the
fever and all.
amount of ointment that has to be
Yeah,
put is
that has to be very. It has to emphasize to the parents that only this much has to be put.
right, right. So does iris pigmentation also affect the choice and efficacy of cycloplegic drops in
Yeah,
pediatric?
ma'am. Usually, my thing I have I've seen that it takes a little more time
Okay,
to get at least mydriasis, if not cycloplegia.
right, right. So, Kritika, do we have any questions?
Ma'am, a question from my side.
Okay.
When we use CTC, cyclopentolate combined with tropicamide, is it tropicamide plain or with phenylephrine, ma'am? What is preferred?
Um, yeah, it's just okay to use phenylephrine. You will get a good dilation and you can see the fundus also very well.
Okay. Ma'am, the CTC protocol is followed for the early dilatation or for any other reason, ma'am?
Because using only cyclopentolate, sometimes the pupil will not dilate fully. Like
Yes,
you
ma'am.
will not be able to see the periphery and do an indentation and see the fundus
Mm-hmm.
very well.
So
That
the
is the main reason, just for
idea
seeing the
basically,
fundus.
correct. So idea basically in retinoscopy in pediatric age group is to get the correct number, which means we need cycloplegia, but we also need dilatation. We need both. So,
Yes, ma'am.
so one cannot be had without the other. So both have their own positives. And if we want to get the correct number as well as check the retina, because like sir and ma'am both rightly pointed out that retina examination is a must. And I think we should incorporate in our practice more often to, dilate at least once a year, even if the number is not changing for
Yes.
the kid, and keep
With
checking the
the
retina.
fundoscopy.
Yeah.
Yes, ma'am. Yes,
Yeah.
ma'am. Yes, ma'am.
And
And I
and for
have received one
myopes,
question. Yes,
myopes, we are also measure. We have to measure the axial length also. If you are having the opportunity to do it, please document the axial length at least once a year, because sometimes in children we'll get some surprises with the refraction, especially if your refraction is just changing, but we can confirm with the axial length. So we can use
ma'am.
both together to get more informations.
Right.
Ma'am, excuse me, I
Okay.
have a question for Dr. Sandra, madam. Madam, whether you're doing this documenting the progression of myopia, are you doing an open field AR or a routine AR, madam?
We are doing only the axial length, sir. Like peripheral open field AR is needed for documenting the peripheral the hyperopic defocus. So we are not having an open field autoref in our center. We are using the Spark, which is developed by LV Prasad Institute, which is an attachment which you can just put on your trial frame and do the retinoscopy. That will show the degree at which you are seeing the angle. So it will illuminate at the correct degree so that you can check your peripheral refraction. So we are doing it with the retinoscope only. That also not in every case because it takes a lot of time.
Yeah,
In any case where we are finding, we are going to
rapid.
prescribe a glass or myopia control glass or something, those cases we'll do.
Otherwise, as a routine for every myop, you're doing the axial length as a baseline,
Axial
madam.
length is mandatory. Axial length, binocular vision, and the FORIA assessment and accommodation,
Lag
these
and
are lag. These are mandatory.
So can I ask one question before Kritika? I think you have one more question, but I need to
Yes,
ask
ma'am.
one. So I was
Sure, ma'am.
wondering, what is the dosage of atropine that you recommend in your clinical practice? Dr. Sandra and Dr. Parveen both. I want to know from both of you, like how do you go about explaining to the parents how they are supposed to instill the atropine ointment? How many times a day? And
Yeah,
for how
so
many days?
1% atropine eye ointment, we give the guide as a rice grain, just a very small, amount, BED for 3 days. And then come on the 4th day for the refraction. That is what we are saying.
So do
Yeah.
you routinely also explain to them that in case the child gets a systemic symptoms like fever or anything, so you'll have to, so do you recommend antipyretic medication in the same sitting, or do you ask them to go to a pediatrician?
Usually, all of them have antibiotic at home. But if we always ask them to call us back in case of any such occurrence, because we just want to confirm how much they applied and all.
Right,
Or
right.
we'll just ask them to stop it and then come also. Sometimes they would have by then applied for 2 days, so we'll just call them.
Right, right.
Yeah.
Okay, okay,
madam.
Kritik.
No,
Yeah,
madam.
sir. Yes, sir.
No, madam, I liked you the last but one slide, madam. The frames you have shown, that is very important when you prescribe a glass to a child.
Yeah,
Because
we'll
Right.
most,
take so much effort, and
yeah,
finally, the child will have a fixation towards a frame, and that will
yeah,
spoil the entire thing.
yeah. Finally, the child will be peeping over the glasses sometimes after you do a
Yes.
good exercise and then it goes waste. I like that slide. Very nice, ma'am, that slide.
Thank you. No, this problem comes in the older child.
Yeah,
They
yes, ma'am.
they want to they have
Well,
something in their mind. Somebody is using in school or something,
Yeah,
and they'll not rest until they find that.
yeah. This point also has to be emphasized to the parents
Yes.
when we're prescribing that. That is
And
very
they will
important.
get a very small,
Very
tiny
small frame. Yes,
frame they
yes,
will
ma'am.
get. The tiniest
That,
one they can
mm,
find. Like
that means it's
presbyopic.
cosmetically appealing. They want that.
Yes. Uh, so that will twist in just
Yeah.
1 week, it will get twisted.
Ma'am, we have one question on YouTube platform, and it is how to confirm if complete cycloplegia is attained or not.
Yeah, so when you do the retinoscopy, and you check the pupillary reflex, and when you get the retinoscopy, again, you will not get a variable shadow. There are 2 ways.
Okay, ma'am. So one is pupillary reaction, and another one is the variable retinoscopic reflex that we get.
Yeah.
Okay, ma'am. Yes, ma'am. Ma'am, another question that I've received, as in a case discussion, ma'am, post traumatic corneal injury, where a kid had a corneal epithelial defect, that's all, with iritis. So treatment has gone for 6 weeks. Post 6 weeks, a kid comes for a refraction, and kid turns out to have a cylindrical refractive error, and the kid's age is 6 to 7 year old. So, would do we prescribe glasses in the same post 6 weeks of injury, or should we wait for another 3 months or so, repeat the refraction and get it done? Vision is 6 by 6 with cylindrical power of -1 or 2.
It is unlikely that the epithelial defect has contributed to the cylinder.
Cylindrical.
Since we do
Okay, ma'am.
not have a previous value, it may be a coincidental finding. Mostly, I feel like that. But if a practitioner is having a doubt, you can. And how long has it been, did you say? post-injury?
6 weeks post-injury, ma'am.
Yeah, by 6 weeks, all the effect would have gone. The epithelial defect in children usually is
Remodeling,
very
yes, ma'am.
fast. Yeah. So I think they need to prescribe. I think the cylinder will be there from before only. You can also get, you can just document the keratometry. If you want, you can do the pentacam scan also. You can do just to see what's happening, and you can keep it as a record, because nowadays if it is bilateral and all in higher cylinder, we also have to rule out keratoconus in
Yes,
higher
ma'am.
degrees of. I forgot to mention about that in the presentation. So whenever a child comes with allergic conjunctivitis, chronic allergic conjunctivitis, eye rubbing with cylinder, it is always better to do the keratometry, and any steep cornea always image, because sometimes it is missed, and then the child loses vision because of keratoconus. But this case, I think you can go ahead. Yeah.
Just wanted to add here that very rightly mentioned that usually we err on the side of saying that okay, children have steeper keratometries, but sometimes keratoconus does get missed when we try to box all the children in a same uh, side, and we think that they'll all have steeper keratometries. But I think it makes much sense to get bit more of history, as in some kids will show blatant red flags, like children might be rubbing their eyes, and if you never ask the mothers will never, the parents will never think to give that history. So you have to always elicit that history, especially if you're seeing a young child who has a higher astigmatism or the K value seeing steeper. Even if you feel that might be age appropriate, always ask a question or two to rule out the red flags. Like, for example, like you rightly mentioned, VKC and allergic conjunctivitis are pretty common in children and should always be asked a history of whether there is any history of eye rubbing. About this patient, Kritika, I
Yes,
think they
ma'am.
should go, the treating doctor should once go for an epithelial map of both the eyes. So that
To
will give
confirm
you
the
a lot of,
remodeling,
yeah, it will give you a
yes,
lot of, because see, the beauty about treating eyes is that you have two organs, and if one gets hurt, you can always compare it with the other to figure out, because most of the time they're supposed to be enantiomers or
yes,
enantiomorphs,
ma'am.
and
Yes,
the
ma'am. Yes,
maps
ma'am.
are supposed to be mirror images most of the
Yes,
time if
ma'am. Yes,
nothing
ma'am.
abnormal is going on. So 6 weeks is good enough time to heal, right?
Yes, ma'am.
But
Yes, ma'am.
but again, when I say 6 weeks is good enough time to heal, what kind of injury was it? What happened immediately after the injury? So sometimes keratocyte remodeling happens for as long as 3 months. Even if remodeling is fast in children, you never know what kind of stromal injury has happened. What is the stromal component of the injury, right?
Yes, ma'am. Yes,
Six
ma'am.
weeks is good enough time. But then if we have something like epithelial maps, always do them and then maybe compare, and that will tell you more, isn't it? Any
Yes,
other
ma'am. Okay,
questions?
ma'am. Uh, no more questions on online platform. Ma'am, will refraction be changed, or will there be any difference in the refraction in a case post sphincter tear?
For sphincter tear, there will be glare actually. So
Yes, ma'am.
for near vision may be impaired. I don't think refraction will change, but near
Anything
vision will
induced or nothing?
definitely, their accommodation will be impaired.
So how should we manage about that, ma'am?
Again, we'll have to, if it is immediately after the injury, we can wait, but otherwise, we have to, some kids will have to give an ear ad for like a progressive ad or something if it is quite severe. And usually it is like when they are binocular, they are not going to be able to make out that difference. So you really have
Mhm.
to see whether the child is very symptomatic and then take a decision on that. But there are children who, when they go out in the sun, they can make out a glare in the eye. So that depends on how severe the sphincter tear is. If it is a fully dilated eye,
Pupil tear.
then you will have
Yes,
to
ma'am.
use some other surgery like pupilloplasty or something can be tried if it is really bad. Yeah, or use photochromic glasses for the time being.
Okay, ma'am.
Ma'am, I have a question. As you pointed out that this refractive error is related to birth weight, was
Yes, birth
it in
weight,
preterm babies or in term babies also, madam?
yeah, both. Term IUG are also high risk only. But preterms, incidence of myopia and myopic astigmatism is more.
No. Okay. Term babies also you had this other thing.
Term babies, see, we
Okay.
are now another whole, the new thing is
Okay.
the cortical vision or cerebral vision impairment,
Yeah.
where we have a whole lot of red flags at birth, including prematurity, term IUGR, any hypoxic ischemic encephalopathy, any perinatal or neonatal problems, any NICU care more than 1 week. It's always better to do a functional vision exam for these children.
So, Kritika, just one more
Yes, ma'am.
line about what you were asking about sphincter tears, no?
Yes, ma'am.
Usually, iris sphincter tears cause more atonic or irregular or mydriatic pupils, like ma'am just mentioned, and
Mhm.
that lets in more light, right? And that can induce something called as higher order aberration.
Yes, ma'am.
Okay.
Yes, ma'am.
Especially, like we said, glare and maybe sometimes reduced contrast sensitivity. Huh?
Yes, ma'am. Yes, ma'am.
Uh, and there might be a slight, hyperopic shift after pupil meiosis, after pupil is small. So in mydriasis, whenever pupil becomes larger in size, there is a slight myopic shift.
A big shift.
But it is not usually clinically very significant. So we see a lot of corneal tear patients who have iris
Yes, ma'am.
injuries.
Yes,
If
ma'am.
sometimes the corneal injuries are not that bad, we repair them, but the patient is usually left with some kind of an iris defect or post cataract surgery. Sometimes we see patients with iris defects. So most of the time, the patients have more of higher order aberrations. They'll complain more about the vision not being very clear and the glare and the contrast sensitivity not being
Quality
that
of
great
vision.
between the quality basically, rather
Yes,
than the
ma'am.
quantity of vision
Quantity.
itself.
Yes,
Right?
ma'am. Yes, ma'am.
Yeah, that is something I wanted to say. Yeah.
So
Any
only
other
thing that we
questions?
can go about in such patients is photochromic glasses in adult age group and kids. As ma'am told, we can give a progressive ad. Is it ma'am?
Absolutely. Absolutely.
Okay. Okay. Yes,
Absolutely.
ma'am.
And yes, you can always try to repair the
Repair it, yeah.
sphincter
If
tear.
it is with the
Very
cataract and
significant.
It's a huge thing now.
yeah,
Iris
right,
repairs
repair,
are the
yes.
next big thing.
Yes,
So,
ma'am.
yeah, you can always try that. Yeah. Any other questions? Do we have anything else? Dr. Praveen, any other
No, ma'am.
comments from your side, sir?
No,
It was a
madam had
great,
very
wonderful
great discussion.
presentation. Absolutely.
Exhaustive
It was a
discussion,
great,
covered very
exhaustive.
basic things also.
Absolutely. It was an absolute pleasure having you here, Dr. Sandra and Dr. Praveen, and with such a wonderful discussion. And I'm sure people would love to come back to this lecture again and again. And thank you very much, Kritika, for your help
Thank
and
you, ma'am.
support.
Thank
So
you.
Thank
if
you so
there is,
much, ma'am.
yeah, if there is no further addition from any of our panelists or the people who are live, we'll call it a day.
Yeah. Thank you.
Yes,
Thanks
ma'am.
again,
Thank you.
all of you.
Thank you.
Yeah.
Thanks
Thank
Thank
you.
you
again.
so
Thank you
much.
so
Thank
much,
you, Dr.
ma'am.
Sandra. Thank you,
Thank you,
Thank
Dr.
you.
sir.
Bye.
Praveen.
Thank you, ma'am.
Good night.